in Italy. I would like to introduce the program this evening, and I would like to send out a sincere thank you to MC Pharma for their unconditional educational grant. Today, and rather this evening, we welcome Professor Leonello Milani and Professor Fillipo Randelli. We're going to start the program this evening with Professor Milani, and his topic is the clinical innovations in the treatment of joint and musculoskeletal and myo-fascial conditions. I'd like to introduce our honored guest. Wonderful having you across the ocean with us, Prof.
Thank you.
Professor Milani has been the scientific director of the Italian medical journals La Medicina Biologica and the Physiological Regulating Medicine since 1997. After graduating in medicine and surgery from the University of Milan, Prof. Milani obtained his specialization in neurology in France, dealing mainly with neuromuscular disease, neuromotor rehabilitation, postural disorders, and segmental reflexes, both from the neurophysical and the clinical-therapeutic point of view. He has taught extensively throughout the world, a number of countries that are listed here. Perhaps he will share some anecdotes with us during the course of his presentation in his experience. And he is also the author of more than 140 scientific articles published in Italian, English, German, and Czech. And he's the author of 7 books on segmental reflexes. Prof. Milani, I'm going to hand over to you, and thank you very much for your time, and we wait in anticipation of learning further from you. Thank you.
Thank you so much. Thank you so much for your brilliant presentation.
Thank you.
Estimated doctors, welcome to the webinar, Clinical Innovation in the Treatment of Joint, Musculoskeletal and Myofascial Conditions. This webinar is dedicated to all the physicians who, in their daily practice, cure the different pathologies, acute, subacute, chronic, of the different anatomical districts of the arthro-myofascial apparatus. They are orthopedics, doctors of rehabilitation, medicine, sport medicine, but also and not least the general practitioners who have from 30 to 40% of their patients suffering from pain, and the 60% of this kind of patients, this category of patients, over 65 years old. I have devoted my medical profession, it's a long profession now, since 1980, so it's 40 years. I have devoted my medical profession to the local therapy of pain due to the musculoskeletal apparatus with different techniques. But the collagen medical device injection from 2010 has been much more effective, less costly, and long-lasting effect than any other technique I used in the past. Moreover, the medical device demonstrates to be safe. So I will begin my presentation giving you some hints about what is collagen. Collagen is the most abundant protein, structural tissue, having molecular weight of 300 kilodaltons in mammalian organisms, accounting for about 5–6% of an adult body weight. That is to say that in a man of 70, normal man of 70 kilos, 4 kilos are collagen. 1/3 or 1/4 of the whole protein mass of higher animals is composed by collagen. Bones, tendons, joint capsules, muscles, ligaments, fascias, serous membrane, teeth, skin, and the extracellular matrix are mainly composed by collagen. In humans, collagen biosynthesis peaks between 40 and 60 years of age. It is called the collagen plateau. But collagen diminishes rapidly in the 6th decade of life, together with the synthesis of elastin and the matrix proteoglycans. Practically, the total collagen pool is halved between 60 and 80 years of age. So in a man of 70–75 years, for instance, the total amount of collagen passes from the 4 kilos I have spoken before to 2 kilos. It means just the half weight of collagen. And this gives reason about sarcopenia in the muscles and the different extra-articular joint pathologies. And here we have the curve. The blue one is the proteoglycans. You can see how the proteoglycans, starting from the very beginning of life, the newborn baby reaches a peak at 10 months of age, 10 months of age, not years, months, then decreases. Practically a baby is composed mainly of proteoglycans, the extracellular matrix, of course. In the red line, red curve, you will see the elastin. Elastin reaches a peak at 15 years of age, then decreases. But collagen continuously is going up from the beginning of our life, stabilize from 45 to 60 years of age, then there is a decrease. Practically, starting from 65, we have the decrease of collagen, proteoglycans, and elastin, and this gives the reason why in this range of age, we have mostly the osteoarthro-myofascial pain and problems. But why it happens? What is the reason why there is this collagen decrease above all? This reduction is governed by the late expression, age-dependent genes that encode from collagenase. Practically, they are called MMPs. That is to say, matrix metalloproteinases, that prevail on the TIMPs, that are the tissue inhibitors of metalloproteinases. Practically, we have the MMPs that are much more abundant than the TIMPs. That's why collagen decreases, destroys, and arrives to be the half of the ratio that it has to have. The TIMPs, that is to say the tissue inhibitors of metalloproteinases and other proteinases like the disintegrin metalloproteinases, have an anti-apoptotic function and are encoded by allocated genes on the X chromosome. This likely partly explains the greater longevity of female who have double XX allosomes versus male. Adrenocorticotropic hormone, ACTH, interleukin 10 and interleukin 6 stimulate the TIMP1 through the inhibition of the metalloproteinases. I remember you that interleukin 10 and interleukin 6 are the so-called anti-inflammatory cytokines. We shall see this topic later. And this is a nice picture who shows you the molecule of collagen. We shall speak 2 minutes what it is, how it's done, and so on. And you see easily how the balance, the weight scale is maintained in the right order when the TIMPs and the MMPs are in the right proportion. But both of them, the TEMPs, which are inhibiting the MMPs, which destroy the collagens, and the MMPs have some helpers. For instance, the MMPs, of course, have as helper the pro-inflammatory cytokines. That is to say, interleukin 1, interleukin 6, tumor necrosis factor alpha, and ROS, the reactive oxygen species. On the other side of the weight scale, we have interleukin 4, interleukin 10, interleukin 6. You see that 6 is both in the right plate than in the left plate, because interleukin 6 can act as pro-inflammatory or can act even as an anti-inflammatory cytokines and tumor necrosis factor beta. But I want to underline that the pro-inflammatory cytokines, the red one on your right, interleukin 1, 6, ROS, and tumor necrosis factor alpha, are those that have a great peak in what it is nowadays called systemic chronic inflammation. So, due to many factors, diabetes type 2, for instance, arteriosclerosis, Alzheimer, and so on, even the collagen suffers a lot. So just imagine how many people suffer of obesity, suffer from diabetes type 2, and osteoarthritis myofascial pain joints. You can easily understand how the two things, well, they go well together. The synthesis of mature collagen is very long, but extremely simple, because it's long as a time consuming, but simple in the same way as they are the same bricks which make this great, big, I would say, mega molecule as collagen is. So the synthesis of mature collagen involves 7 intra and extracellular steps, from the so-called pre-collagen, 2 steps, to pro-collagen, 3 steps, to tropocollagen, 1 step, to collagen, 1 step. Collagen is made inside the fibroblasts, but not complete, because it is a too long molecule to be mounted inside one single fibroblast. So it has to be mounted outside the cell in a way that it is easy disposable for the tissues which needs collagen. 2 words about the father of collagen. This is Narayana Ramachandran. When he was young, he was the good student at Indian student in Oxford. And then when he was more mature, the 3 books you see are the 3 wonderful books on collagen that Professor Ramachandran, who was a biophysic, wrote. And this is the so-called Madras group, because collagen was born in Madras, India. There are 20 researchers, most of them very young. In the middle, you see Professor Ramachandran when he was young, some assistants even. And these 20 young, I would say more than boys, young men, studied for many years what is collagen, why it is done in this way, and what was the reason. So if we know many things about this great molecule, three-dimensional molecule, we have to thank this Madras group. I remember you that Madras is the old name of what today is Chennai in India. And this is the small house where collagen was born. On your left, you see the first photograph of collagen. How is made collagen? How is made? How can this mega molecule can stand up, can stay in the space? And this photograph is the first one taken from the top, showing the different bands and the very first ideas about the possible three-dimensional structure of collagen. I say possible simply because it was not easy. It took more than 15 years for understanding what we know now. And what we know now is that the ultrastructure of the collagen, that collagen, this is a native collagen fiber, type 1. So you see that you see many bands. This is a tropocollagen fiber. You see many bands with dark lines between whitish lines. We shall see why it is formed in this, I would say, zebra-like figure. It is just like a metameric structure. We know now that from one band, black band, to another band is not 64 nanometers, but it is 67 nanometers. It is not just a curiosity, because this was a work for more than 3 years, because for understanding how can the collagen molecule stand up, it has to be exactly 670 Armstrong, that is to say, 67 nanometers. In the black box, you see an enlargement of the transmission electron microscope 150,000 times. So it is an extremely high resolution. And you see the fibers, how they are well parallel, how they are well made. Those are native collagen fibers, that is to say, normal collagen fibers, and they are without any cross-linking. But here we have what happens simply in a medial collateral ligament. It is just a medial collateral ligament of the knee. You see at the top on the left, the normal. You note how they are very well aligned. They are parallel, not cross-linked, and they have a quiet disposition in the space. If we just give a look on our right, we see the fork fusion of collagen fibrilles. You see how many fibrilles they tend to fork, and in this way the tensile forces are not good enough for giving to a tendon, for instance, or a fascia, for instance, the right flexibility and the right force. On bottom, on the left, you will see a wound healing process. It's just a wound healing. You know how the disposition of collagen is completely disrupted. Many bundles forms, many groups forms, they lose all the verticality, they lose all the parallelism, and this is just what happens in a wound healing process. So it is not a restitutio ad integrum, because it is just a repair. Cannot be a restitutio ad integrum. It is just a repair, and it is repair like cement to try to stop a hole in a wall instead of putting the bricks. The other microstructural damage is produced by overload. I am talking always about the medial collateral ligament. You see that even low overload, certain sports, certain activities, especially soccer, especially judo, especially karate, especially artistic dancing, where they have to twist the knee several times, they suffer from the medial and lateral, in this case, the medial ligament, and you see what it is exactly, the ultrastructural. Without these photos, we cannot understand why collagen is so important for a normal behavior of the muscular myo-fascial muscular apparatus or system, if you want. The great curiosity is that this mega molecule is formed by triplets. That is to say, 3 amino acids that joined with other 3 amino acids, that joined without other 3 amino acids, and so for a very long period of times. But the curiosity is that these triplets are made only by 4 amino acids. So we know now that amino acids are more than 20, 25 according to different authors, but only 4 enter in the collagen formation. And these are mainly glycine, proline, and hydroxyproline. That is to say that even the last one, the hydroxyproline, is just like the first one, the glycine, with a hydroxylide group, OH, in the 4th position. So, complicated, yes, but simple, yes. Here you see that, like, the complication do not arrive by a complication of different situations, but just positioning the same thing in different ways and put together to form a greater thing. In this case, I have selected, you see on the right up, it is a section of the Achilles tendon. Is formed by 3 bundles, the same that you see on the right of the slide, but they are done exactly like the small first one in green you see on your left, which is tropocollagen. Then tropocollagen makes microfibrils, many microfibrils makes some subfibrils, then fibrils, bundle, and then finally the tendon. The other strange thing is that these triplets begin always with the same amino acid, that it is glycine. Point number 1, every triplet of amino acids always starts with glycine. So we can have glycine A, B, that they are the other 2, or glycine AA, or glycine BB, or glycine BA, but always becomes clear that each triplet begins always with the same amino acids. The other strange thing is that these triplets cannot usually be found in other proteins. So they are very special because of the many, I would say, thousands ten of thousands proteins that we have in our kind of proteins that we have in our body. The triplet glycine, proline, hydroxyproline is represented only in collagen. And this gives a reason, because this configuration of these triplets that go from the very north to the very south of the collagen fibers give to the molecule special characteristics. The special characteristic, you will see them in bold letters, are strength and rigidity, but even resistance and flexibility. Imagine that to break 1 millimeter diameter collagen fiber, we need a weight of 11 kilos put at each end. It means that these microscopic fibers put together to form a fibril of simply 1 millimeter can be broken if we apply 10 kilos weight. It means that strength, rigidity, resistance, and flexibility, and those characteristics are due to the special configuration in space of this triplet of amino acids that which are more or less are the same. Only 4 enter in the formation of collagen. And here we have the three-dimensional, the so-called the triple helix, 3 alpha chains of tropocollagen, that is the basic unit of mature collagen. I have also put a curious photo of a cellular cord, because even the cellular cord have to have the same characteristic of collagen, and they are done by a triple helix, in this case, of cord. So 3. 2 do not produce the same, 1 not at all, 4 no, 3 is the best for making this long triple helix. Here you see, I come back to some slides before, the bands, the different bands in number 2, I said black bands and white bands. And this happens because practically each fibril has to slip of 1/4 on the other fibril, which is under, and the same happens for the under again. And after 4 slips, they become to be as they beginning. And when they are in the same position, you see the black bands. When they are slipped, one in front of the one with the others, you can see the white single bands. So the characteristic of this mega molecule, which Professor Ramachandran wrote in one of his papers, a charismatic molecule, is resistance, not extensibility, not compressibility, but also plasticity, flexibility, load resistance, torsion resistance. And this gives to the collagen its extraordinary possibility. Last but not least, collagen also is an antioxidant, as it is demonstrated in vitro. Those are beautiful works produced by Aleman and colleagues, and Nachman and colleagues very recently, just 4 years ago. And now we begin to put all these brief knowledges to the extra-articular compartment. An extra-articular compartment is formed, 1, by the synovial membranes, 2, articular capsule, 3 extra-articular ligaments, and 4 muscle tendon. So the importance of the I do repeat, the importance of the extra-articular, extra-joint compartment in the joint stability, because only knee have intra-articular ligaments. Only hip has an intra-articular ligament. In some cases, not all, especially in some races, shoulder has an intra-articular, but all the other articulations in our body, starting from the temporomandibular to the foot, to the radiocarpal, to the elbow, they do not have intra-articular ligaments. So are the extra-articular compartments that put together and makes an axial line, or not necessarily axial or not necessarily coaxial, due to the different lines, knee for instance, elbow for instance, that do not follow the same line of the upper part. And now a new substantial and refined approach to the painful dysfunctional pathologies of the musculoskeletal system and of the related motor function is offered by the medical devices produced here in Italy for use in clinical practice and in specialist facilities. The 13 Guna medical device contain collagen, all the same quantity, plus an ancillary substances of natural origin. And this ancillary substance of natural origin is different from one collagen medical device to another. So the difference between one and the other 13 is given by the ancillary substance. The so-called ancillary substances allow a more effective and specific placement of collagen and have the function of conveying and stabilization. This was the first slide. Collagen medical devices are present since 2010, so it's already 10 years. And here we have the synopsis of the first injectable Guna medical devices. The name is very easy because they take the name from the anatomical part that we want to cure. Of those 13, we can say that 9 are specific for the articulation. So we will have a medical device neck, thoracic, lumbar, shoulder, hip, knee, small joints, poly, ischial, and those are specific for the main anatomical joints. But also there are medical device, other 4, medical device muscle, neural, matrix and tissue, then can be used alone or can be used in combination with the other 9 before said, and we shall see, and you can ask all your questions you want. Another interesting, important thing to be remembered is that Guna MDs can be used by themselves, practically one vial, or along with different associations, up to 2, even 3 ampoules per medical device, according to the specific need of the patient. For example, medical device neck plus medical device muscle, or medical device neck plus medical device muscle, plus medical device, for instance, neural, because the problem of the cervical spine does not involve only the bones, but even the muscles, even the tendons, even the fascias. So a neck problem is not a cervical problem, it's a neck problem. That is to say that even the other parts that go together and make the anatomical part are interesting for diagnosis and for the cure, of course. And now I want to present you one interesting work, very recent. This work has been performed in the Department of the Temporomandibular Disorders, Medical University of Silesia, Katowice, Poland. It has been done by Dr. Niceta Bukta and other three clinicians. This paper has been published on Pain Research and Management, which is a very good medical review with a very high impact factor, peer-reviewed, of course, and much known. And it is the comparison between collagen and lidocaine intramuscular injections in terms of their efficacy in decreasing myo-fascial pain within the masseter muscles, a randomized single-blind controlled trial. The purpose of the study was to analyze which was the best medical device muscle in the trigger points of the masseter muscle due to a temporomandibular joint TMJ dysfunction, or lidocaine, which is very much used for this kind of conditions. So the participants were 50 participants from a group of 102 patients, and this underlines the fact that all these patients were chronic, because these trigger points in the masseter, monolateral or bilateral, that, you know, this TMJ problem, temporomandibular joint problem, is very painful because people cannot eat, people cannot speak, people cannot even sleep in the night, because the trigger points in the masseter muscles are very deep and very hard to shot and to kill. These patients were suffering from, they were chronic, average 8.5 months were identified and included in the study. So there were 50 patients with temporomandibular joint due to trigger point in the muscle, in the masseter muscle, who were suffering from long time. They were divided. From 50, they arrived to be 43, because 7 refused to take part in the study. So these 43 patients were divided into 3 groups, group 1, group 2, and group 3. Group 1 with collagen medical device, 50 patients. Group 2 was a control group with lidocaine, 2%, other 13 patients. And group 3 was simply a neutral control group with a sterile saline solution. You can see that the groups are very homogeneous in number, in age, and had, of course, the same grade of pathology. The study has been evaluated with the VAS, the visual analogic scale, and with electromyography. In red, you see the 3 groups. First group, red, green, and blue. Second group, red, green, and blue. Third group, the same colors. So the red is the baseline of the group treated with the first red is the baseline from the group treated with medical device. You see that they had the same VAS, because the red lines, the 3 red lines of the 3 groups have reached VAS 8, which is high. But you can see that in the very first follow-up was after 7 days and after 14 days in the group medical device. At 7 days, From 8, it arrives to be 4.5. See the green, the first green on the left. And arriving at 14 days to be 3 and 3.8. If we analyze the other two groups, we see that we don't have this dramatic decrease in VAS, that means pain, visual analogic scale on 0-100. In this case, not 0-10, but 0-100. But it decreases as the other do not do. The same happens if we choose the electromyographic superficial changes. You see in the first group, that is to say the medical device group, the electromyography after 14 days of study practically is reduced from 70% to 25%. It is a decrease of the 70% of the 70%. But this does not happen in the second group, lidocaine, and of course, this does not happen in the third group, sterile solution. The conclusion of the authors is that this study showed that intramuscular injection of medical device muscle in the masseter muscle is more efficacious than the intramuscular injection of lidocaine, of course. Here, I present you just some spots, 5 remarkable clinical papers on Guna collagen medical devices. The first one I will not comment because Professor Randelli, my friend Professor Randelli, will comment it. So I pass to number 2. This is a wonderful work. This work has been published on BMC, musculoskeletal disorders. Very good, very peer-reviewed, high impact factor. It was a multi-cohort study, so a multi-center study. They have evaluated a double-blind, randomized, active control clinical trial on the intra-articular use of medical device knee versus sodium hyaluronate in patients with knee osteoarthritis. So in this case was the medical device knee versus hyaluronic acid. Practically the two, at the end of the study, the two types of treatments were equally effective. It is to say that medical device knee in the treatment of knee osteoarthritis is as effective as sodium hyaluronate. And this is a great, they had no systemic adverse effect in both groups, no joint effusion. You can read all these papers because we shall give you detailed information. You can read by yourself. I just wrote on the left part of the slide what are the topics to be remembered. The other study is the ultrasound guided collagen injections in the treatment of the supraspinatus tendinopathy. The case is a pilot study. This was also published in Advances in Musculoskeletal Diseases and Infections. And the results are that for the supraspinatus tendinopathy, that is to say the frozen shoulder, in this case was medical device shoulder, is as effective as the other kind of therapies, or more effective, but especially much more less costly. Much more less costly. The other one is a recent study. Practically all were chronic cases, all were lateral epicondylitis treated by collagen injection. In this case was used medical device tissue, and the patient were suffering from 6 months, so were the chronic patients, and practically they showed a total average of reduction of pain of 57%. So the 60% of pain was taken off. And for function, at a 1 month follow-up, the reduction was the 62, no, exactly was the 63% in terms of function at the 3 months follow-up. So very good result. The last one is a study. I also have been, I participated as a clinician in this study. Was performed by Professor Pavelka and collaborators. The collaborators in this case were from Czech Republic and Italy. Were published in 2019. And in this case, the study was designed on the efficacy and tolerability of injectable collagen-containing products in comparison to trimecaine. Trimecaine is a local anesthetic like lidocaine or novocaine. Specifically, trimecaine is lidocaine in patients with acute lumbar spine pain. So this is a very frequent low back pain treated, in this case, with a combination of 3 medical devices. There were, of course, the medical device lumbar, because the cases were all low back pain, plus medical device muscle, plus medical device neural. And the result is that both groups also showed statistically significant improvement in mobility and quality of life. On the other hand, consumption of paracetamol, because it was given the possibility when they needed to take paracetamol to the patient, the consumption of paracetamol as a rescue medication was significantly lower in the group treated with collagen medical device. Here is a list that you can download in our website of the 36 now different papers. Practically, I tell you that these papers are focused on practically all the joints of the human body. There is on the left the pathology, the title of the article in the middle, and what kind of medical device have been used. This is the first page of the list, the second and the third page. I will finish my webinar with, as well as I began, with collagen. To understand the form of collagen, that means that in nature, the form makes the function. To arrive to achieve, to put this molecule in the way how it is present since the millennia in the living mammalian and not mammalian organism, many years of study have been performed. And one artist made glass and steel sculpture. He is Julian Vas-André in 2013. And this beautiful sculpture named Collagen, it is in the center of the campus of the Rutgers University Center for Integrative Proteomics Research, Piscataway, New Jersey, USA. For further information, that means the brochure for all the medical device, all published articles. I do repeat, all the published articles can be read online and download, so you can print and have and study and control. The news and the media events are on the website collagenmd.guna.com. The last words, thank you so much for your kind attention. I hope, because I do not see you, so I hope that you have been attentive. And I just want to finish in a souvenir. Next November 16, it is already 1 year that the second International Medical Congress on the medical device has been performed in Milan. There were more than 500 doctors coming from 21 different countries in the world, and they have been all satisfied, and we shall publish very, I hope, in 2, maximum 3 months, all the papers, or the papers who have been sent to us to be published, and to give you as a souvenir of what you could not see 1 year ago, but nowadays we can see together in collagenmd.guna.com. Thank you so much for your beautiful.
Thank you. A fascinating discussion, Professor Milani, and we were reminded of our physiology and biochemistry, which has been very informative for us. Thank you so very much for that. Professor, there are a couple of questions that have come up, and I'm going to just read them to you there. There's a question: is this treatment modality available in South Africa? And who does it in Cape Town and in Durban? And I'm just here, Denver, you mentioned the clinical applications will be presented by our next guest. So I suggest that we go ahead with our next honored guest in the program. And I'm going to invite Professor Fillipo Randelli. Prof, if you can share your screen, and then after you've given your discussion, your presentation, we can look at some questions and look at the application of this intervention in our country, in South Africa. Professor Milani, thank you so much. Wonderful to have the insight from a neurologist. And now we are going to have some more discussion from an orthopedic surgeon, Professor Randelli. Can we see you there?
Can you see me?
Yes, we can see you. Wonderful.
Oh, great. So
Excellent.
First of all, I would like to thank you.
Thank you. So, Professor Fillipo Randelli, if I can briefly introduce you, and then you can go ahead with your presentation. An orthopedic surgeon, and you've specialized in hip and trauma surgery. Since 2010, you've been the contract professor on the Milan Orthopedic and Traumatology Residency Program. You graduated in medicine from the University of Milan in 1996 and completed an AO Trauma Fellowship in trauma at the Hospital for Special Surgery in New York. in 1999, and you passed the Italian Orthopedic and Trauma Board exams cum laude in 2001. Prof. Randelli is a consultant editor for the Journal of Orthopedics and Traumatology and chair of the ESSKA Hip Arthroscopy Committee and involved in the board of different scientific societies. Prof. Randelli, I'm going to hand over to you and thank you once again for being with us and enlightening us. Thank you so much.
Thank you. It's a pleasure to be with you. Here in Milan, the moon is rising up, so it's late. I'm going to talk to you about one specific pathology and introduce you how I did get in contact with this collagen that Professor Milani just talked to you. So the pathology is a pathology that is very frequent and is the main cause of the lateral hip pain. I'm mainly a hip surgeon now, and you should consider that half of my patients come to me because of lateral hip pain. So it's very frequent. So how did this story start? Once I was thinking about how bad it is for us to treat a recalcitrant greater trochanter pain syndrome, and then I will explain you what it is, on a lady. Because this pathology, this is the X-rays of the lady, you don't see almost anything about wrong in this X-ray, but this lady was suffering since years of lateral hip pain, and I really have tried everything on her, and nothing succeeded. So when you do an MRI on this patient, you can see there was a mild inflammation, but this patient could not even sleep because of their pain. So let me first introduce the problem and talk to you about the peritrochanteric space. So the peritrochanteric space is a crowded space that it lies between the fascia lata and the greater trochanter. There are many tendons there, and there are also bursa. Different bursa, but the main one, the more involved, is the subfascial bursa. So the external part of this space is the iliotibial band, which is made by the fascia lata, the gluteus maximum, and the tensor. It is something that's pushed against the trochanter and may create a pathology. So let me take you inside this space. I have just incised the fascia lata, and now I'm detaching the bursa, the subfascial bursa, the greater trochanter bursa, and you see that in this case it's mildly inflamed, and I'm removing it. Then my finger pass below the gluteus medius with this tendon, and that is the vastus lateralis. So it's a crowded place, not so easy to be really known. And this is an endoscopy. I mean, this I am just done 2 small cuts and introduced one camera, and I'm looking at the greater trochanter. I'm looking at the gluteus medius with the tendon, and I'm moving inward and outward the hip to check for the tendons. So the main pathologies that affect this area are the external snapping hip, the trochanter bursitis, and the gluteal tendon lesion. The last one is the more important, is the one that really is tricky to be treated. So the trochanteric bursitis is the inflammation of the bursa over the greater trochanter, as I told you, and is well known since 150 years ago. So the bursa can be inflamed and can be easily seen if you open it. But you should know 3 things about this bursitis. The first one I have already told you is very, very, very frequent. The second one is that it mimics other pathologies. And the third one, that the bursitis itself is not a pathology. It's just the clinical sign of a pathology. Why the bursitis often mimics radiculitis? Because there is a small nerve with an inferior gluteal nerve that, going back to the central nervous system, pass through the fifth lumbar root and the first sacral root. So those are the same roots that create the sciatic pain. Another important thing is to know this pathology. The Greater Trochanter Pain Syndrome is a pathology that as a clinical feature, the bursitis, the pain of the lateral side of the hip, but the genesis of the pathology is a tendon pathology, is a degeneration, inflammation of the gluteus, medius, and minimus tendons. So something that could create this inflammation is a tightened fascia lata. It means that the tight fascia lata will create a compression over the tendon and create the bursitis. It's not the only condition that can create this pathology over the tendon, but the Greater Trochanter Pain Syndrome is the name that we give to all the conditions that can create the tendon pathology. I think you better know the rotator cuff tears of the shoulder. The same thing happened to the hip. So there have been some authors that have described the pathology, this pathology, as rotator cuff tear of the hip. If you imagine the fascia lata as the acromion, the greater trochanter as the greater tuberosity of the shoulder, you see that you have a bursa and you have two main tendons that is between the acromion and the greater tuberosity. Which are the clinical signs of this pathology? The lateral hip pain is the main one. The problem of the lateral hip pain is that he has many different diagnoses that can create him. And this is a young boy that I met many years ago that had a lateral hip pain, that spent weeks to do physiotherapy without any X-ray. Then he did an ultrasound that was negative, so he was back to the physiotherapist to do a lot of physiotherapies and physical therapy. At the end, he came to me, I did an X-ray, and this is a tumor. It's not a bad tumor, but locally it's very aggressive. So to check if the pathology is there, I mean that the pain is coming from there, you just need to touch the area of the greater trochanter. Pain at palpation is very specific for a problem that comes from the area. The second thing that you can see is a snap. You see this lady, when it's flexing the hip, you can see a snap over the greater trochanter that is followed by pain. Another clinical sign, clinical test you can do is the Ober test. If you put the patient plays in a lateral decubitus position, and then you keep the ankle and you try to have the knee against the floor, you see that those patients who has a retraction of the fascia lata will have some difficulties. Another sign that could have is the weakness of the muscle because sometimes for the rupture of the tendons. And you see this young boy that had a tear of the gluteus medius. The diagnosis. The first one is the clinical examination I've shown you. Then you should have X-rays to check out concomitant pathologies, to check out if there is ossification. You can also do an ultrasound, but the main examination is the MRI that give you the definitive diagnosis. On those patients, you may see ossification at the insertion of the greater trochanter, but you can see here the white, that means inflammation and edema around the greater trochanter area with a detachment of the gluteus medius. This patient is mainly affecting two kinds of persons, mainly female, I'm sorry, but not only female, young and middle-aged one. They sometimes have the snap and tendon lesion, and older ladies, that is the vast majority of these patients. They have degenerative tendon lesion. We have heard from Leonello Milani that collagen tends to go down with age, and maybe this is one of the reasons those patients have pain and degenerative changes on their tendons. So this is a young lady with a hole in the gluteus minimus that we have seen through a scope, and then we have repaired. You see the rest of the tendon is okay. The tissue is white, the belly is red, everything is okay. This is another kind of patient. This is an older one. You see how the tendon is completely changed and degenerated. So two different scenarios. Which is the treatment of these pathologies? The first step is always conservative. So rise, then weight loss, activity modification in the athletes, physiotherapy. We try to stretch the fascia lata to make it longer. And then if they have a leg-leg discrepancy, we compensate them. We use also anti-inflammatory disease, much less today. Somehow some shockwave therapy, they may succeed for a while. And then we do injection. So you see how many kind of injection have been tried in the last decades. Even just dry needling means to make some scratch in the tendons through the skin, then corticosteroid injection, and mainly today platelet-rich plasma injection. Someone has tried to do some autologous tenocyte injection, and so on. So when in orthopedics we see too many different treatments for a pathology, it means that we don't really have a good one. Let me talk to you about steroid injection. I don't like them, even though I'm still using somehow, because especially in this pathology, you have good results in half in the patient, but then the results usually goes down with time, even though because it's not so easy to get really the bursa, also because steroids near the tendon may create more problem in the long term than good things. So we rarely use it today. And if everything doesn't go well, we do surgery. Most of the time today, we do endoscopic surgery with prostatectomy. We release the band, the fascia lata, to give more space in the peritrochanteric area. We do also tendon repair through scope, but we still use somehow the open surgery because it's much more easy to do a repair of the gluteus if they have a very big tears. We can also use allograft to augment. If the tendon is completely degenerated, you cannot do a direct repair. You need something between. We also do gluteus transfer. I mean, we take a part of the gluteus maximus and we take over the greater trochanter. But usually they do not give this kind of surgery very good results. At the beginning of the 2000s, when I started my practice, we were using to do minimally invasive open release of the fascia, but was really a blind surgery, and we couldn't do anything on the tendons through very small holes without a scope inside. If we have to release the fascia lata through a scope, we have three different ways. The one is to go above, lateral to the fascia, and to cut the fascia outside in. Another method is to cut the fascia from inside to outside. And the third one, which is the one I prefer today, is not to cut the fascia, but to cut a kind of vincula that the fascia lata has to the femur through the distal insertion of the gluteus maximus. So this is an example on how we release the fascia from outside in. The patient is in lateral decubitus. We create a space over the fascia, outside the fascia. We go in, we don't see anything at the beginning because we have to clean the space that is not a real space. We create a space above the fascia, it's bleeding. We spend time to see at the end. You see, we move to check where the trochanter is, and you see now the fascia, the white fascia is clean, is tight. And so then we started to cut with the electrocautery the fascia. We do a longitudinal and then a transverse incision of the fascia. And we also cut a little bit of the gluteus maximus, of the anterior margin of the gluteus maximus. And then we do the bursectomy, because that is the greater trochanter. Another way is to go inside. You see in the upper part of the video, the greater trochanter that is moving up and down, and you see the fascia. I'm trying to push the fascia apart, and then I cut it from inside out. So different way to get the same result. Release the fascia to have more space above the greater trochanter. The problem is that cutting the fascia may have some consequences. And the consequences is a painful scar. So you remove the pain because you need space above the greater trochanter. You get the space, but then you have pain because of the scar you have created. Nothing is easy in the world. So this is Giancarlo Polesello, who has an Italian name but comes from Rio de Janeiro. He's a hip surgeon like I am. And he discovered that the iliotibial band has a small tendon that goes from the gluteus maximus to the linea aspera of the femur and keep the fascia lata and the iliotibial band itself near to the trochanter. So he thought, if I cut not the fascia lata itself, but the vincula of the fascia lata to the femur, may I have the space that I need to have a free greater trochanter? And the answer is yes, you have it. And this is another video that shows you that we are always we are inside the bursa now, and we are checking the tendons of the gluteus maximus that keep the fascia lata and the iliotibial band towards the greater trochanter. And you will see it in a few seconds. The white strips that you see there are the vastus lateralis. And this is the tendon, okay? It's like a strip that goes from the fascia lata, from the iliotibial band to the femur, and we cut it. Without touching the fascia, we obtain a good space. But here we solve the problem of the tightened space, but we don't solve the problem of the tendon pathology, because the tendon pathology usually is already there. And if a tendon is degenerated, it's very difficult to make any suture. So we need not to get to this point. We need something to save the tendon before. Okay, now you see on the left the insertion, the gluteus maximus insertion on the left is untouched, and on the right is touched. We also may do a repair, as I told you, through a scope, but it's really not easy and sometimes not successful. You see, we put a kind of screw with the suture that goes inside the greater trochanter, and then we pass through the tendon, the suture, to keep the tendon back on its footprint, and then you have the rehab. But this, you can do this if the tendon is okay. If the tendon is already degenerated, it's too late, and you need something more, with the results that are not always very good. So let's go back at the beginning. So I was thinking, what can I do to this lady who has a gluteal tendinopathy, has pain, has tried everything, and still has pain. This is the patient, the MRI, and one sales rep came to me in the same period, and she told me, I have a new fantastic medical device for trochanteric pain. And you know, I'm very skeptical. So I said, you have the solution of one of my worst problems in my clinical practice? Let me see the literature you have about its use for a greater trochanter pain syndrome, and if convincing, I will use it. Oh, I don't have it. I'm very sorry. So let me see your study in vitro on tenocyte. You know, tenocyte are the cells that produce the collagen and create the tendon somehow and repair the tendon. So please let me see your study with tenocyte. How do they react to your device? Oh, she didn't know that. Even though there was already, and Leonello Milani showed you a very nice literature, nothing was already done specifically for my problem. This is how a study was born, because of a clinical need. So we wanted to see the effect of this swine-derived collagen on cultured human tenocyte, focusing on the collagen turnover pathways. That means, for me, tendon healing. So we took some small pieces of tendons from my patient. I asked them if I could, of course. I passed through an ethical committee. We selected patients that did not have any problem on their tendons still, but they have to do a total hip replacement. We had some inclusion and exclusion criteria, try to have the best tenocyte that we could. And this is a clinical picture, is an intraoperative picture. When you see the hip capsule on the top, you see the gluteus minimus belly on the bottom left, the vastus laterali on the bottom right, and you see a pickup that is pointing on a small white piece of gluteus minimus tendon. We took very small pieces and then we cultured. For this, I am an orthopedic surgeon. I had to call one of the best scientists of collagen that we have as Professor Milani, and she is Professor Galliano. She's working at the Biomedical Science for Health, especially on the extracellular matrix lab, and you know the link that is with the collagen and extracellular matrix, Professoressa Galliano. And she did everything for me. I mean, I gave her the piece of tendons, and she did everything for me. She first cultured the cells, and then in some of the culture, she put the Guna MD tissue, the collagen we are talking about tonight, and others were cultures were left alone. And then she did a lot of tests. Most of them, I didn't even know the presence, but I will try to explain it to you. Okay, the first one is the proliferation. I'm sorry. So what happens if I put something, a collagen near tenocytes? It happens that they proliferate. It means they grow. If cells grow, is a good thing. This is very easy. But what about collagen? Tenocytes create collagen. What happens if I put this Guna MD tissue nearby? Do they still create collagen? Yes, they do more, much more of the control. That is what's significant. And what about they interfere, this material interfere with the cells, with the collagen maturation? No, the stability was not affected. Does it create degradation? We heard about MMP1 and 2. No, the degradation was not enhanced because the TMP1 was was good. Okay, so it was increased. So the TMP1 is increased, the MMP1 decreased, and so the collagen is not degraded. Do they move? Do they create focal adhesion? This was much more difficult to be demonstrated, but it seems that they're good and they move and they create focal adhesion, but this is yet under review. What is best for a simple mind as an orthopedic surgeon is this test. It's called the wound healing assay. You should imagine the control on the left and the MD tissue tenocytes are on the right, okay? You create a culture of cells, and then you make a scratch. You create a lesion inside, and then you wait and see what happens. And what you see on your bottom right, that the gap is filled with a lot of cells within 24 hours, much more than the control. This is a clear explanation of healing, the healing protection of these cells. So this Guna MD tissue showed us that cell proliferation rise up, the collagen synthesis was rise up, the degradation was reduced, and the migration was good. So good news for me. And I could also publish this on Cells with a very good journal. It was not so easy to publish. We have to review it 8 times for small things, but they accepted. So we had the rationale to use this device in a clinical settings, investigating its real role in the common pathology of the Greater Trochanter Pain Syndrome, but also in other tendon pathologies. So we started to use it in our clinical settings. Now is more than 2 years that I'm using it. The protocol is quite easy. First, we have the clinical history of the patient, then the clinical examination, the physical examination. We touch the trochanter, we move the hip, we move the spine, we do a LASEG, we do a Wassermann test to check everything. We do X-ray because it's not so rare to have arthritis in this patient. Then we do an MRI to check for the inflammation and the status of the tendons. We start always with physical therapy anyway, and then if needed, and most of the time is needed, we do 3 injections of Guna, and we are seeing very good results. I cannot show the results now because we are starting a clinical study. You will have it in the next future. But this is an example. This patient was a 74-year-old lady, severe left lateral hip pain. She already had a spine surgery, and you know that L4 and L5 disc is strictly correlated with the lateral hip pain. You should know it. And so we did an MRI, and you can see on your right, that is the left of the patient, a lot of white around the trochanter, a lot of inflammation and pain. And this was, you know, one of the first patients 2 years ago. And we say, let's try it. Let's do the Guna injection. And you see, this is an axial view of the MRI, the same white. And this is what happened 1 year ago. The inflammation was not completely resolved, but was reduced more than half. This is the comparative images of the left is the past, and now is the last one on the right. The patient was clinically much better. And we are still using it, and we are very happy to use it. So thank you very much for your attention.
Thank you so very much, Professor. We were fascinated to see some of those practical videos that you showed us, shared. Fascinating to see that the technology is amazing, I have to say. And so we would like to open up the questions. There are some of our clinicians who would like to know more about it in this country. We ask them to please type in their questions in the chat box. But in the meanwhile, we have Denver Wickham with us, who is familiar with the Guna product. Denver, there were a couple of questions about the product, the availability in this country, also who can utilize it. Has it been registered? And with the funding side, I know that you're working harder on that. But Denver, can you translate some of this exceptional information that we've just learned this evening and understand what the availability and access is for us in South Africa?
Thank you very much, Adi. So to give you a little bit of background, that this is the first introduction of the actual product in South Africa. The product has recently, I think about 2 months ago, been registered in South Africa and is available to be going to the shelves of pharmacies. At this point, the clinical information has been presented to the funders, and in terms of reimbursement and application, the product is certainly available. So it's a novel a product that's been brought to the South African market and has been available in Europe for a number of years. In South Africa, it's quite new. This is the first introduction. We've just done the introduction today, and certainly we'll be applying more of it inside more specific and probably more defined groups. So we will be presenting the product to the orthopedic surgeons at the South African Association of Orthopedics at their congress to be held next month. And then also if there are specific applications within both general practice as well as your normal orthopedic surgeons, our sales team will be presenting the clinical information both via be it Skype, webinar, email, to communicate the information through to the clinicians at this point. So yeah, it's still fairly new at this point.
Thanks, Denver, for that information. So possibly what we can do is find out what the uptake is with our delegates and colleagues who've joined us. Possibly they can contact us if there's a need for more clinical information. Obviously, this is a clinical forum. I know that the product that Guna offers is novel and unique to us. So that is why we are opening up the discussion around the product itself, mainly because it is a novel offering, and there is some interest in understanding its application and where it can be accessible and the appropriate patient for the use of the Guna injectable collagen.
Adi, if I can give a bit of background to the actual Guna collagen, it's been around for many years in Europe, and certainly this evening, firstly, let me say thank you to Professor Randelli and Professor Milani for the presentations. It was really insightful to see the clinical applications, and I'm sure we'll see a lot more of it going in future with the doctors and with the orthopedic surgeons in the presentation of the actual application of this Guna collagen. But I think when it comes to mind and you think for a first time about a collagen, I think in South Africa particularly, we've had some supplementation of perhaps oral supplements where we've used collagen via oral route. We know of some of the aesthetic practitioners that have been using it for sort of superficial acne scars and that type of thing inside the face. But certainly the applications are vast, and it's not a definitive science. And perhaps I can pose this question, and I think I maybe have a part of the answer. But Prof. Randelli, in terms of the application of the actual product, we know there are 13 different SKUs of the product, the stock keeping units. So there's from the neck to the ischial to the knee, and there are various applications throughout the body. But as far as my understanding, this is not an exact science. So it's not something where you can say milligram for milligram, this is the dosage you will treat a patient, because what you want to do here and what your idea here is sort of the regeneration or the improvement of perhaps the cartilage and the collagen within the body. So can you perhaps give us an idea in terms of how you define specifically the dosage and the volumes that you'd be using on a particular patient, depending on what the patient's condition is? Professor Randelli?
Yes, here I am. I'm sorry. We still do not have a definitive answer to the question, which is a logical and very important question. Although we are started with a protocol of 3 injections because in the hip, in that specific pathology, usually we are doing 3 injections of steroids or 3 injections of PRP and so on. I suppose that this product can be used widely than only 3 injections, but at the beginning we decided to start as is the normal protocol for other products. I know it's not very scientific, but you have to start with something if you want to do some research. And we will try to maybe do a research trying to get the real dose that patient need. Sometimes we have used more than 3, sometimes even 6, 9, and sometimes we have to repeat the injection after 6 months. But maybe we should wait. Of course, they have less collateral problems, and so I would never do a 6 injection of steroids near a tendon, never. But I can easily do some Guna of about 6 and even more, okay, because of the properties of the molecule that I'm injecting.
Okay. And specifically, if a patient comes to you, for example, and the patient, as an orthopedic surgeon, you're perhaps posed with a patient that comes to you with a tennis elbow or epicondylitis, and you need to treat this patient. Certainly sending the patient away with an NSAID or a non-steroidal anti-inflammatory drug and booking the patient with physiotherapy, you probably might lose sight of the patient in the long run, because you're not gaining full control of the patient's recovery then, because the patient is then treated in another environment with another clinician, and then you can't really monitor the regression or the improvement of the disease. And I think you with this opportunity in terms of treating the patient with collagen probably have a better understanding of what the improvement is. Is that correct?
Yeah, sure. If you do something like this, maybe the patient come back to you and you can control it. I have to tell you that I've tried also this molecule on tennis elbow and so on, but this is not my main pathology. People knows me because I'm a hip surgeon in trauma. I don't use in trauma, of course. But when I see some patient with tendon pathology, I've tried in my practice and I have good result, but there are so few cases that I'm not doing a definitive word. But of course, if you do this, then the patient usually come back to you to tell you if it's going well, and if it's not, you may decide to change your direction.
Okay.
Thank you, Professor. And the thank you, Denver, for guiding us, and I'm sure there are a few more questions or comments that you would like to make around the use of the injectable collagen. But the use of a multidisciplinary team here, the physiotherapist and others who are treating the patient, surely that is an important component in understanding the efficacy and the outcome and success in the holistic treatment of the patient.
Yeah, sure. And I have to tell you, I'm not doing the injection myself. I have some radiologists that they do ultrasound guided injection, but you can even do without ultrasounds. I mean, there are many surgeons in Italy that they do themselves, but I do prefer to take the skill of a radiologist with an ultrasound to guide the injection. And then the physiotherapist, normally I use some of them that they know how to stretch a fascia lata in this case, because it's not so easy. I mean, if you don't have the right protocol to do it, you may think that it didn't work, but was not a problem of the methodology, it's a problem of the skills.
Yes, understood. So this is really giving us better insight into the application of the injectable collagen and how the specialist goes about making decisions, and again working as a multidisciplinary team. As you say, the radiologist is a team member, and this gives the patient the best outcome, really.
Yeah.
Thank you for that. Denver, I think let's make another 2 more comments because there's such a wide application here, from my understanding, of the injectable collagen. There are 13 different applications, if I'm correct.
Yes,
Possibly you can guide us around some of the more common applications.
I think probably for the use in orthopedics, the knee and certainly the hip would be the 2 most common. But I think one must understand the basis of it, and the collagen has got a lot of regenerative properties when it gets to the extracellular matrix, the improvement of the collagen in the extracellular matrix, both in tissue. There is one that is specific to muscle as well. And remember, the product has got an ancillary substance that sort of helps in attraction of that product, of that collagen directly to that specific area. So we have, for example, one of them that might have onica that will help with relieving the pain. But certainly the clinical information so far has shown that with a vast majority of patients, that after the 3rd week, there is already an improvement in their pain, and that your improvement is certainly going to be one of longevity. So it's going to be something that you're looking at, rather regeneration, rather than just treating the symptom. You're trying to treat the cause, and you're looking at a long-term solution to patients that potentially might not even need surgery, or perhaps are suffering from a common injury. So I think there are long-term applications for this product, and it's certainly the applications are going to be something that I think the more you use it and the more experience you get with it, you'll certainly start seeing the results over the longer term, and you get the opportunity of managing your patient over a longer period. So weekly injections, depending on what you're using and what the combinations are, of which you've got a lot of clinical information available to a lot of the clinicians we will provide into the market. Those combinations that can be used can certainly be, we will try and distribute that out. And the product is available right now. This is the first introduction. We will be doing much more on local levels and more specific levels, where we'll be getting more speakers to try and express their interest and their application of the product. But certainly we'll be giving more information out to the market in future.
Thank you for that. That's really interesting, and also looking at it from a cost effectiveness point of view, if much more aggressive surgery can be avoided and length of stay in hospital, etc., that often is preferable for the outcome of the patient and the cost at the end of the day, which all of us are very aware of in every way. So thank you to you, Denver, for enlightening us further. And Prof. Randelli, it was such a pleasure to meet you and to introduce you to our colleagues in South Africa from around the country, whether they're sitting in the sweltering heat as I am, or some of them are much cooler down at the seaside by the coast. We've all been fascinated with your sharing your knowledge, and certainly some of those graphic videos has really been incredibly interesting. Dr. Milani, Professor, you're still with us. We were delighted to meet you as well and introduce you to our colleagues. And we wish you both well, and we wish to say to you, stay safe, and thank you so much for your time today, this evening, and being with us in South Africa.
Thank
Thanks,
you.
Denver.
Thank you very much. Thank you. Bye-bye.
Thank you. And
Thank
we
you.
wish you a good evening.
Ciao.
Stereo.
Thank you,
Ciao.
Adrian. Thank you for the PTCMA for organizing this event, and thank you to our colleagues in Italy for presenting us with the opportunity of sharing your expertise. So it's really been a privilege for us, and we look forward to having many more of these professional development activities going on in South Africa. Thank you.
Thank you.
Bye-bye.
Good night to everyone.
Bye.
Yeah.
Goodbye.
Good night. Thank you so much.
Bye. Thanks, Philippe.
Thanks.